Welcome to another episode of The Breakdown. Oh, what a week in health it's been. We set up the interview that we are about to have a few days ago, thinking that we were going to talk about one thing. And then in the space of those few days, we're now talking about much more than one thing. The real impetus for this interview, before we got derailed with healthcare being lit on fire, was because we wanted to talk about the changes that have been made to the chief medical officer of health. And in order to do that, we reached out to somebody who's been on the show before and has been very extraordinarily, some might say, patient with us. So we're very excited to welcome back to the show Dr. Lorian Hardcastle. She's an assistant professor in the Faculty of Law at the University of Calgary with a joint appointment to the Department of Community Health Sciences in the Cummings School of Medicine. And then there's more paragraphs here that are very impressive. So we'll just say Dr. Lorian Hardcastle is awesome. And it's a thrill to have you back on the show, Dr. Hardcastle.
Thanks for having me. I'm excited to be here.
I'm so like, for a little bit of context for our listeners and our viewers, I sent a very panicked message earlier today being like, hey, so I know that, or I think it might have even been last night. Hey, so I know that we're scheduled to do this thing. Can we bump it by like 12 hours? Because apparently the universe is going to collapse. And we're going to talk about that in just a bit. But first, we're going to talk about the CMH. So help me God. So, Dr. Hardcastle, to start with, do you feel like there was undue legal confusion in regards to who was supposed to manage I don't know, perhaps a minor pandemic once a public health emergency was created? Do you think that there was legal confusion out there?
I think there was, and it was unnecessary. The Public Health Act has and has always been crystal clear that the chief medical officer of health is the one who issues public health orders, either in the day-to-day kind of situation or in a public health emergency. Section 29 of the Public Health Act said that. Despite that, what was happening during COVID, as we later found out, was that somehow Dr. Hinshaw came to believe that she was merely an advisor and the government was treating her as merely an advisor. Although when it was convenient for them, sometimes they would say, well, these are her decisions. And so the legislation wasn't matching up with reality because she was the decision maker in the legislation, but cabinet was dictating the terms of her public health orders to her.
So, I mean, maybe I need to rephrase my question a little bit, because there's no doubt, I think, that there was some I'll use the word illegal things that happened in regards to the public health orders. I feel like I'm safe to say that because I'm pretty sure a judge did. But it it seems like there's sort of two sides to the equation, if you will. On one side, we have all of the legislation that you listed off there, and on the other hand, we have Mr. Kenny and co. saying, "Hey, how about if we just made all of the decisions?" And Dr. Henshaw, some might say inexplicably, saying, "Oh yeah, I'm just in an advisory role." Do you think there was a flaw in the legislation? Was there a flaw in how her role was communicated to her?
It isn't clear how all of the misunderstanding came to be. I think the legislation is clear to anyone. Plus, you would hope that the chief medical officer of health who's writing public health orders has legal advice. And so it's not clear how she came to believe that she was merely an advisor. With respect to the government, they too obviously had access to legal advice, and they must have known what the legislation said. And also the government had opportunities where it amended the Public Health Act during COVID and could have brought the legislation in line with reality, and they wouldn't have been out of line in doing so. There are provincial models where cabinet does have more decision-making authority in a public health emergency. So they wouldn't have even been an outlier. But it seems as though they wanted a situation where they could have their cake and eat it too. When things were going well, they could, be at the podium telling everyone how great they had done and how they had balanced lives and livelihoods. But when things were going poorly, they could say, well, these were Dr. Henshaw's ideas. We followed her recommendations, and that's what they said when Open for Summer turned out to be a big flop in the fall.
And this is where, like, as this whole thing is kind of unfolded, I found myself to be quite confused because in the early days of the pandemic, we had you on the show, we had Dr. Obako Bogu on the show as well, and both of you were very clear. Oh no, this is hers. Like there was no, oh gosh, if only there was some sort of legal clarity here. It was, this is hers. And it seemed like the confusion that most people were experiencing who understood or had been told by people smarter than them what the legal framework was. The confusion was more, why are they doing it this way? This isn't how it's supposed to work. Am I like having
Yeah,
a Mandela
no, that's
effect moment?
that's
Or
that's absolutely fair. What there was just a complete misalignment between the law and what was happening in reality, and it's not clear why the government didn't resolve that. And so I don't blame the public for being confused and wondering who the decision maker was, because you had Dr. Hinshaw, who wasn't accurately representing the legislation. You had the government, who seemed to be waffling on what their role was, and all of it was unnecessary. They could have amended the legislation to begin with if they wanted to be the decision makers. Cabinet could have made themselves the decision makers, and indeed that's what we're seeing this week is new legislation that would shift power to cabinet in a public health emergency.
yeah, and we're going to get to that in just a sec. I just really wanted to go through it because to me, it was kind of like if somebody walked into a convenience store and took a handful of like Snickers bars and then walked out, and the cop said, "Oh, you're not allowed to do that." And the person with the handful said, "Oh, I thought the clerk said I could." And then the clerk said, "No, no, I didn't say that, but you took them." And then there was confusion over not whether or not the law was broken, but who broke it. And it seems like that's kind of what happened in regards to the health protections and the health orders that were issued. It's not a question of whether or not the the health orders should have happened. It's more a question of how they happened. Am I representing that okay?
Yeah, yeah. So what ended up happening was there were two cases, one by parents who were concerned that masks had been rescinded in schools, and then a group with the opposite view of public health orders, a group who felt that the public health orders were unconstitutional. And in both of those cases, the court didn't seem concerned with the substance of public health orders, and indeed, in the charter case, the court said no, these public health orders were necessary. Hospitals were struggling. So it's not that the court didn't support the public health orders themselves, but they said they were the product of improper delegation, that these public health orders weren't valid because Dr. Hinshaw had delegated her authority to cabinet. And so what ended up happening was there were a bunch of cases where charges were dismissed, or there were acquittals because the public health orders that people had been charged under were invalidly enacted. Not that their substance was wrong or problematic, but that the government hadn't followed the proper process in enacting those public health orders.
Now, to be clear, because I've seen a lot of chatter on social media, and God knows there's the folks who inevitably have some form of cryptocurrency in their bio who talk about, see, the health orders, they were all illegal. And to paraphrase what you just said there, it's not that the health orders were illegal. It's the manner in which they were implemented was not how it's supposed to happen. So to my knowledge, at least, there hasn't been a court ruling saying, "Oh no, these orders were invalid because they breached the charter," or "These orders were invalid because of bad science." The verdicts that have been rendered have been verdicts saying these orders are invalid because that's not how this is supposed to happen. It's not that the outcome was bad, it was the process was bad.
Yeah, absolutely. I think that some of these cases have been misrepresented, where in the one case, Ingram, the court said that the public health orders are consistent with the charter. There was just this procedural issue. But following that decision, you're right, on Twitter, there were people sort of talking about it being a victory for freedom and the rights were vindicated. And that's not what happened. They lost on the charter issue. It was simply the fact that the public health orders were improperly delegated.
Okay. So it seems to me, and I'm not going to ask you to say this because that wouldn't be fair, but I'm going to say it. It seems to me that the problem that exists with the way that the public health orders were developed was that Dr. Henshaw did not hold her role in the way that the legislation said she was supposed to. And politicians, and I feel like it's safe to say we're not just talking about Mr. Kenney, we're talking about cabinet, given that there were presentations that were given to all of cabinet, and cabinet didn't say, oh, we shouldn't be reaching in and doing this. This is supposed to be the reign, the purview of the public health experts. So government certainly overreached, and Henshaw didn't smack their hands back.
Yeah, it is not clear how this happened. I mean, as someone in the position that she was, Dr. Hinshaw should have had advice, access to legal advice. Cabinet should have had access to legal advice. And indeed, there are members of cabinet who are lawyers. So it isn't clear how anyone at the table didn't realize that this was the situation. And so it isn't clear if they just chose to ignore it, or whether they were planning on making legislative changes post COVID. It isn't clear why they allowed this situation to persist, or perhaps they thought nothing would come of it. But it's frustrating. It's frustrating, to those of us who were saying that this isn't what the legislation says. It was frustrating to see public health order after public health order that had these legal issues, be it the issues with improper delegation, or some of the issues around the public health orders not being made available in a timely manner, or some of them were poorly drafted, they were lacking definitions, or had other drafting issues. They were just a frustrating mess, despite all of the access to legal advice that the individuals behind them ought to have had.
I think it's safe to say, and this is purely a hypothetical, so we're just going to speculate a little bit. Do you think it's safe to say that if maybe Cabinet and Dr. Henshaw had listened to the episodes that we did, they might have saved themselves a whole bunch of trouble?
Well, I mean, there were the episodes you did. There were other podcasts. There were op-eds
Sure.
that someone in the government had to see. There were Twitter threads in which some of the government's own policy advisors engaged. I don't know how they couldn't have known this.
Yeah. Um, I don't disagree with you, but I wanted to make sure that we really fleshed that out, because the takeaway for me as a non-lawyer, non-legal expert, I mean, there's a lot of people who say that my biggest credential is hack podcaster. I lean into that. Uh, but the biggest takeaway is it wasn't a problem with the laws. It was a problem with the people following the laws.
Yeah, absolutely. The law itself, which put decision-making power in the hands of a scientist, many people would say that that makes perfect sense during a pandemic, that having someone who is insulated from political pressure and who has the scientific background, that's who you want to make decisions. Of course, other people have a different view, which is that, these decisions aren't only medical in nature, but have political, economic, social dimensions, and so that they should be in the hands of elected officials. So there are people with both views, and you could draft legislation that reflects either view. We just happen to have legislation in place that situated the power in the hands of the chief medical officer of health.
Okay, which brings us to the new bill, and this is Bill 6. Um, what was your? I'm gonna not pontificate too much just yet, but what was your? I mean, we knew that something was coming. What was your reaction on your first reading of Bill 6?
I wasn't surprised. I think that it was clear to me that the government wanted a situation where the day-to-day public health decisions would continue to be made by the chief medical officer of health and the other medical officers of health, whereas in an emergency, where there are the broader orders around masking or business closures or those sorts of things, that cabinet would want those in their hands. And so the way that the legislation was drafted, I think, reflects that.
What do you make of I guess I have so much dissonance with this bill and the justification for it. I'm going to try to work through some of that with you. I have a feeling I'm not going to resolve very much of it just because I have a fundamental problem with the logic behind it. But what do you think of the argument or the logic that, hey, you know what? If it's a small scale thing, if it's one individual, if it's one location, then science is awesome and we should listen to it. But if it's a bigger situation with larger potential loss of life, then we should leave it in the hands of the people who don't have any medical or scientific or ideological or any of those things background.
Yeah, I think it's a huge problem that in a public health emergency, if one were to happen following the passage of this bill, that the decisions would be in the hands of cabinet, and the government isn't doing anything in the legislation that would counterbalance that. And so I would have liked to have seen a bill where if cabinet is to be the decision maker, then the chief medical officer of health is made more independent. And so, at the very least, we would get access to their recommendations and their advice. And there are models for that. And so, for me, that would have been a better balance, that if cabinet is going to decide, we still get to see what those recommendations were so that people can make decisions for themselves and their families accordingly.
Okay, so all of that being said, then, um, I mean, it seems like your inclination would be that in scientific problems, there should be the 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 balance of the decision making should be held by people who understand the nature of those scientific problems. What do you make of, I mean, one of the arguments that we've seen the folks who have introduced this legislation, one of the arguments that they've introduced has been, well, we had to do this because there was so much confusion and we had to resolve the Ingram issue.
Mhm.
And that, unless I'm missing something, that seems to me to be a little bit of a, I'll go with disingenuous argument,
Yeah.
because the the Ingram decision was, you didn't follow the rules, you should follow the rules. And it seems like, to me at least, what Bill 6 is the government saying, but we don't like those rules. We're just going to write the rules that we would like, and that's what we're doing. Am I reading it wrong?
No, Ingram could have been resolved in two ways. One, Ingram could have been resolved by the government leaving in place the existing legislation and merely following it. In some ways that would have been the easiest solution, or the government could have amended the legislation. And they had a variety of models open to them that I think might have been preferable. So, for example, there's at least one province that has a model where the chief medical officer of health makes orders and then they get approved by the minister. And so the orders are still being driven by the chief medical officer of health, but they're getting that government sign off to say, yes, or we identify these problems. Or they could have adopted a model where cabinet is the decision maker, but the orders, the recommendations that led to cabinet's decision become public. And so then if cabinet doesn't adopt those recommendations, then all of us can hold their feet to the fire for failing to do so. But this current model has not only cabinet as the decision maker, but the chief medical officer of health doesn't have independence to do that. They report to the minister. They're basically a bureaucrat serving the minister, as opposed to having that kind of independent role where we would actually get to know what was happening and what their true recommendations are.
Is there anything in Bill 6? Because it seems to me, and I have a couple more questions on this topic before we move on, but it seems to me, if you're going to say, hey, you know what, if it's a small thing, if it's just a couple of, I don't know, preschools and a kitchen, then the CMOH can totally, they can run that show, even though my understanding is there's local levels of chief medical officer of health who could do that without the provincial one having to get involved. But to say, if you're going to make the jump from, but if it's a big deal, then we're going to leave that in the hands of the politicians who live and die on a 4-year cycle. Um, One would think that there would be something in the legislation that would say, and the chief medical officers of health recommendations must be publicly available. Is there anything in the bill that covers off that in better words?
No, no. It what happens now is that the chief medical officer of health would report recommendations to cabinet, and the chief medical officer of health has asserted in the past that those communications are all confidential. And then under the new legislation, what would happen is cabinet would then make the decision. So we wouldn't see the recommendations. We wouldn't know the rationale behind cabinet's decisions. We would just get a public health order saying, here's what's happening. Or perhaps more likely in Alberta, we would get no public health order and we would all be left wondering, should we wear masks? Should we stay home? What should we do? No one's telling us. The government can't even be bothered to encourage people to get vaccinated. So, in Alberta, we would all be sort of just left floating in the breeze, not knowing what we should do. And that's a sad state of affairs when not only is the government willing to act, but people can't act on their own behalf because they're not getting that information about what a chief medical officer of health would recommend you to do. So it's a difficult situation, and it takes what was already a very politicized issue in Alberta and makes it more political. That's what this legislation does. Is it explicitly says that public health emergency decisions are now political decisions.
Yeah, for me, the thing that I keep bumping on is the notion that anybody who's in elected office is somehow qualified to make these decisions. Because if you were going to make the argument that a layperson um, can make these decisions for themselves, then you wouldn't need a chief medical officer of health at all. But we do, because most people aren't experts in epidemiology or virology or public health or and so it's just stunning to me that we're willing to say, like, hey, you know what, the politician who may be, and I'm not denigrating anybody who's been a mechanic or a farmer or whatever, um, they should be the ones making these incredibly complex decisions by nature only of the fact that they were elected and have a public opinion gun to their head.
Yeah, it's these things like a pandemic are so specialized, and the information was flowing so quickly, the science was complex, that we shouldn't expect individuals to have to try and understand this, and we shouldn't expect cabinet to be able to understand these issues in the same way that a chief medical officer of health whose entire job is public health would understand these issues. And so this really minimizes that person to merely an advisory role, and maybe cabinet would listen to them, maybe they wouldn't, but none of us will ever know.
I'm curious, you mentioned other models. Are there any other provinces in Canada or territories in Canada who have purely the government will be advised in secret and then the government will make all of the decisions and cross your fingers suckers model?
There are a range of models with respect to the chief medical officer of health's authority. So there are models like ours at the one end of the spectrum, and then there are models at the other end of the spectrum where cabinet is the one making the decisions in a pandemic. So either through regulation or through ministerial orders. And some of those jurisdictions that have more power in the hands of cabinet did perform well during COVID. For example, most of the maritime provinces were regarded as well performing during COVID, and some of them have a model that is more cabinet heavy than our current model is. And so, on the one hand, we might say that it's problematic for cabinet to be the decision maker, but on the other hand, I think it's actually who's the cabinet, who's the decision maker, because I think some of these powers are fine in one person's hands, but in another person's hands, they can be quite problematic. And so in some provinces where cabinet was the decision maker, cabinet chose to take a very cautious approach, an approach that would try and minimize COVID cases as much as possible, protect hospital capacity. And that's what Cabinet wanted to do. And they leaned heavily on the science and heavily on their chief medical officers of health. But I think in Alberta 2023, those have powers in the hands of our cabinet, we wouldn't see any of that. We would see very little in the way of public health. Even under the previous government, under Premier Kenney, we were often one of the last provinces to put restrictions in place, or the first to pull them back. And we had embarrassing hospital capacity problems after their failed open for summer. I mean, we were talking about rationing and sending people out of the province, which is embarrassing in a province with the health resources that ours has.
If I remember right, we actually needed the military for a bit of time there. So
Yeah, absolutely.
nailed it.
That whole situation was just absurd that AHS was being sort of pushed to find beds, find beds, find beds, and the government was doing comparatively little on their end to prevent those beds from being needed in the first place.
Yeah. Um, I guess if I was to find a silver lining on this, this situation is a presents a compelling argument to elect the best qualified, most reasonable candidate, regardless of party lines, perhaps.
Yes, certainly some candidates show themselves to be more receptive to experts and to listen to experts. And those kinds of people you could expect might behave reasonably in a public health emergency and would lean heavily on a chief medical officer of health's advice and would probably follow that advice. And it would probably be fine. On the other hand, we've seen candidates that are heavy on the ideology, or who are perhaps in a more of a contested area and their constituents are saying, we don't want these public health restrictions. And those people, I think, would be beholden to their base or to their ideologies and may lean away from following the science.
Let's move on into, we're having a conversation about the type of candidate, the type of elected official, and the values that they bring to the table. Um, and one of the pieces of legislation that a lot of people were expecting to potentially see this legislative session, but that um, Minister of Mental Health and Addictions, Dan D. Williams, has said they've kicked down the line. Daniel Smith said they've kicked down the line. Look for it in spring. Is they call it in what is probably one of the uglier branding exercises that I can imagine, compassionate intervention. Everybody who works or has some knowledge of addictions and treatment, I have seen refers to it as forced treatment. So, boy, where do we even start with this? Were you expecting to see the bill, the legislation for forced treatment coming into play this legislative session?
I was actually. I was surprised to see when I saw that there was an announcement related to legislation and mental health and addictions. That's what I was expecting. Instead, we got some minor changes to the legislation allowing us to recover healthcare costs from opioid manufacturers, distributors. That's what we got. But when I saw the announcement, I was absolutely expecting it to be about compelled treatment of individuals with addictions.
Yeah, there's some fascinating interpretations of that Legal Recovery Act just by the name alone that were certainly floating around social media, and it turned into we're including the one other category of people involved in the dissemination of these drugs that were involved in the lawsuit. So I'm sure there's like some legal nerd out there who's just like, oh, this is wonderful. But I think everybody else was like, oh, that's it. But let's talk about the compassionate intervention or the forced treatment. Are you aware of any other jurisdiction in, let's start with just Canada, that does forced treatment?
So under provincial mental health laws, so not laws specific to addiction, but laws that deal with mental health more generally, there are provinces that do allow, in certain circumstances and with certain procedural protections in place, for individuals who are involuntary patients to be treated without their consent. And it's not uncontroversial. There have been discussions about how that may be problematic from a charter perspective. So even that is controversial, and that's existed for a number of years. But expanding it to the context of individuals suffering with addictions, I think, is concerning, especially in this province where they've really not wanted to make the full spectrum of services available to individuals with addictions. They've wanted to disregard the harm reduction sorts of options and instead focus on recovery based solutions. And so I think that, where you don't have other options available to people, you're funneling them into this recovery based model, and then you're potentially compelling them to receive treatment. I think that's problematic. I think it's legally problematic. It's problematic from a policy perspective, and I don't see how it's going to be effective.
So I want to talk a little bit about the other examples where there's forced treatment. We hear members of the UCP and people who are advocating for this new thing often referring to, oh, well, we already have these things. So we have the things like mental health forms like Form 1, Form 10. But the criteria for those, certainly a Form 10, is, I mean, you have to be saying, I want to kill myself. I want to kill that guy because he's a lizard person. There has to be some, I'm not just angry at him. There has to be some sort of psychological defect. And a lot of people look at those and go, well, death's a pretty clear endpoint. When the goal is, I want to get to death to myself or death for someone else, there's not really anywhere to go from that. And it seems like there's some people who are delineating, I'm probably one of them, the difference between I would like to use drugs, I would like to get high, versus I want to die. There seems like there's a bit of a difference in the permanence of those goals. Is there a legal argument for, like, if somebody, and you mentioned the fact that there's charter concerns for things like the Form 1 or the Form 10 or the all the other numbers in between, but is there some sort of legal delineation between somebody wants to make a bad decision and somebody wants to end their life?
Well, it's interesting, despite the fact that these laws exist across the country and raise obvious charter issues, even in the mental health context, and have been expanded in the mental health context from that point that you mentioned, where you have to be a danger to yourself or others, to many provinces have expanded that to allow for involuntary hospitalization where people are at risk of significant deterioration, or they're not quite at the point where they're threatening to harm themselves, but based on their past history, it's projected they'll get there. And so there's been an expansion even in the criteria that we use to involuntarily hospitalize people. Despite that, there hasn't been a lot of litigation in this space, and we can imagine why. These people in this position aren't necessarily well positioned to mount a legal challenge. There was a legal challenge in Alberta a couple of years ago, and actually the court found themselves deeply concerned about some of the things that were going on in Alberta's hospitals with respect to patients with mental illnesses. They were concerned about the number of people, the length of time they were hospitalized for, some of the procedural problems they were accessing along the way. And so when the courts have got their hands on this issue, sometimes they have been concerned. And I would expect we would see the same thing in this space.
I mean, the revocation of a charter right is, to my understanding, a pretty big deal. That's why they have the Oakes test, I'm told.
Yeah.
So if you could talk about that, is there a test? Is, like,
Yeah.
with the pandemic, we had the Oakes test to suspend the charter rights because the world was toxic. Is there some sort of equivalent for, I don't like that guy and his doing drugs.
Yeah, so I think that if the government were to pass legislation that compelled individuals to receive treatment, I think that violates the right to life, liberty, security of the person. So Section 7 of the Charter. I don't think there's any question that that raises issues around liberty and security of the person. The question then becomes, though, those charter rights aren't absolute, and the government has an opportunity to justify those charter rights. And you've mentioned the Oakes test. And so what the government has to show is that its limited rights for a reasonable, a pressing objective. They've done so in a way that minimally impairs individual rights, and they've been proportionate in their approach. The issue I have here is that these cases almost always center on this question of minimal impairment. Could the government have dealt with this issue in a way that impaired individual rights less? Did they have other options? Do they have evidence for what they're doing? And I think the answer to do they have other options is yes. You know, this is a government that is pushing people into recovery only, and is abandoning harm reduction. And they should be giving people as many options as possible, trying to meet them where they are. And, you know, even then, this may still not be justifiable, but in its current form, where they're not even bothering with trying to give people options to safely consume or those sorts of things, I think this is very vulnerable to a charter challenge. And then the second piece is, you know, the courts expect the governments where they're going to limit individual rights to bring the evidence. And I don't know what evidence they're going to bring in this case. That this is effective and that this is going to work and that we have good reason to limit individual rights. I don't think that evidence exists. The evidence that I've seen shows that this may do the opposite. It may drive people away from seeking help. It may have the opposite effect and may actually make things worse. And the courts are going to expect that evidence from the government, and perhaps that's why they've delayed this bill to next session is to try to address some of these issues.
It seems like though what the government is doing, I mean, that's a fascinating. I love the notion that because this government has actively worked against harm reduction, they may well be shooting themselves in the foot when it comes to this legislation. Because honestly, my personal standpoint is any argument for harm reduction is worth considering. But I'm curious, like, what's the legal difference between like what Daniel Smith, what the UCP are arguing, what proponents of forced treatment are arguing is, hey, if somebody is doing so much drugs that they're risking ending their life. I don't think that there's anybody who uses drugs regularly who's not aware of the toxic supply, who aren't aware of the risks for a variety of extraordinarily complex reasons that I'm not in any position to judge. They continue to use. Some of those may very well be physiological because dope sick sucks. But if somebody makes that choice, you know, if somebody's to say, absolutely, I understand that it's a toxic supply because y'all won't give a safe supply, and I understand that I could die, but I choose to continue to use these drugs because that's my choice. What's the difference between somebody saying that and somebody saying, this is my life? I have a terminal condition and I'm going to avail myself of something like MAID. It to me, if somebody is able to demonstrate that they're aware of the inherent risks of their choices, or the likely or definite outcomes of their choices in the instance of MAID, they're allowed to make that choice, are they not?
I think what maybe is that yes, there are healthcare contexts like medical assistance in dying, or like you want to do not resuscitate order, or you have a religious objection to receiving blood. So there are circumstances where we certainly do allow people to refuse treatment and or withdraw treatment and let the consequences be what they may. I think what's happening here and what we see in the mental health context more broadly is perhaps just paternalism. This notion that maybe these people don't actually know better. And I think sometimes it comes from a difficulty that those making policy have with putting themselves in other people's shoes. I think, your average elected official can imagine what it would be like to have painful terminal cancer and want to receive MAID, but they maybe aren't so able to put themselves in the shoes of someone who's using addictive substances. And so I think there's a paternalism and a lack of understanding that's often at play.
It almost seems to me that the disconnect in the conversation is there are people who work in treatment, in outreach, in harm reduction, in all of those different areas, and I think all of them would probably make the argument that there is absolutely a medical component. There's a physiological component to and a psychological component to why people use in the way that they do. And it almost seems like the people who are advocating for the forced treatment are looking at it purely as a moral imperative and disregarding all of the other things. And, you can have I can have my moral feelings about a lot of different things. I have moral feelings about a lot of the pop music that's in the world today, but I also recognize that I don't have the ability to make people stop making crap music. I mean, we're all stuck with Nickelback. That's just the reality. But that seems to be the big difference is like there's this moral piece and then there's this evidence-based science piece, which kind of folds back into the whole CMOH piece, because again, are we making decisions on the best available evidence, or are we making decisions based on purely subjective feelings?
And I think that's a problem. That's a problem that the direction that the healthcare system in this province is taking is that it's one that's moving away from science and experts, and at times has been openly hostile to experts, and towards one that is more ideological in nature. And I don't think that anybody's going to benefit from that. I don't think that the health outcomes of Albertans in a public health emergency or Albertans who are struggling with addictions, I don't think any of that is going to be improved by a government that turns its back on science and heads towards ideology.
Is there legal consequences? So let's use the pandemic example, and then I want to ask about where courts tend to side when it comes to evidence over feelings. But is there? I've seen people who have made the argument: if there's another pandemic, God help us all, but if there is another pandemic and the government does nothing, we're going to sue them into next week. Is that something that people can avail themselves of, or is the government by nature of their positions? I mean, I know that you can get away with not literal murder, but you can say some pretty nasty things inside the legislature that if you were to say outside of the legislature, there's consequences. Does that exist, or is that just wishful thinking? Like if hypothetically we do have another pandemic, and if hypothetically the provincial government says, cross your fingers, everyone. Is there legal recourse, or is it just wait till the next election?
Unfortunately, it's largely wait till the next election. I know a lot of people talked about wanting to sue the government for the way that it managed the pandemic, and there were conversations about, well, isn't this negligence? Weren't their decisions negligent? And the issue that we have with the law of negligence is that what it does is it does two things. One, it insulates policy decisions from the review of courts in negligence law. So if the decision is a policy decision, as opposed to executing that policy or carrying that policy out, the courts won't touch that in a negligence case. And so a lot of what people had problems with during COVID would be policy decisions, the decisions not to bring in masks or not to close businesses, or to not allow you to have people at your house, but to allow you to go to the mall with 10 people. All of those things are really policy decisions. And so the courts would be very reluctant to say that government is negligent in that space. And then the other thing that we see courts saying in negligence cases against government is they talk about the government having a duty to the public as a whole and having to balance different interests. be they economic, be they health, be they whatever, and that the courts aren't really, they're not in a good position institutionally to make those decisions for governments. They don't have access to the same information that government does. They just have the injured person sitting before them. And so they don't have that same institutional expertise as government. It's hard to sue governments in general. And there were cases actually after SARS where people tried to sue the Ontario government for its management of the pandemic, and those cases went nowhere for the reasons that I mentioned.
So I guess elections have consequences.
They do. Elections absolutely do have consequences. And I think another legal tool that people sometimes talk about is, well, can't we use the charter to make the government do something? And the charter doesn't tend to be interpreted that way in Canada. It tends to be interpreted more in a negative way, as in, did the government limit your rights? Not, can we use it to make the government do things? And so the legal recourse for mismanaging a pandemic is fairly limited. It really does come down to the ballot box.
What do you make of, because I've heard a few people float this idea, and since I have you here, I'm just going to throw all the things at you.
Sure.
I've heard some people say, um, if we have another pandemic and the government decides to be stuck on suck, well, we're going to do the recall legislation. And I mean, I've read the legislation, and it requires almost a higher level of signatures than voter turnout. So I'm not sure how well that works.
I think it would be extremely difficult to use recall legislation to get rid of particular elected officials or government. Even if there was a horribly mismanaged pandemic or some other similar situation. The issue is, the number of signatures. Another issue is that it's time limited. You can only recall people a certain number of days after they've been elected or a certain number of days before an election. So there are time limits, there are percentage of voter limits. I don't think that we can rely on that legislation as really providing much of an out. And it's by design. The government wouldn't have put legislation in place that makes it easy to get rid of them.
Yeah. I remember when the whole recall legislation came up and everybody was like, ha ha, they're putting in the recall legislation, and they were pleased because somebody said it's recall legislation. And then if you actually read it, it was like, oh, so I should be buying lottery tickets because I have better odds of that.
Yeah.
Let's talk about, I mean, we're recording this on the 8th of November. Remember the 8th of November. It's not quite how it goes, but I'm making it work. We had a big announcement today. There was some foreshadowing yesterday where there was a big document dump / leak that sort of foreshadowed what was going to be announced today. Describe for me what happened, and then we'll get into what you make of it.
Sure. So, Alberta had moved historically from a situation where each hospital had its own governance structures, and then those were amalgamated into health regions. And then we ended up with Alberta Health Services, which is a single health delivery organization that deals with acute care and various other health services under their umbrella. What this legislation would do is it would shrink, well, when there is legislation, it will shrink the role of Alberta Health Services down to just an acute care provider among other acute care providers. And instead, we'll be bringing in 4 new organizations, each of which will manage a different part of the healthcare delivery system. So there will be a primary care organization, an acute care organization, continuing care, and one for mental health and addiction. So we'll have these 4 organizations, each tasked with different managing and administration of those areas. And then the government itself will seemingly be taking a much more hands-on issue. They talked about how AHS got too big and was doing too much budgeting, too much policy, and that those functions of policy making and budget should fall with the government. So they're going to be a lot more hands-on, I think, in the coming years.
I love the rhetoric of, oh, AHS is way too big, said the government.
Yeah. Yeah.
Like the notion of, sometimes an organization just gets too big, it gets out of control, so we're going to absorb all of their power onto our mass and trust us. There's just a dissonance in the messaging for me there. um what's your immediate reaction to the way that this has been? I mean, there's a bunch of implications that I want to go through with you, but I want
Mhm.
to get sort of your high level. What are your big thoughts on what's been presented thus far?
So I think my biggest concern is that this is going to take us back in time. It is no coincidence that Alberta has moved towards trying to integrate services under a single entity, AHS. That's happened across Canada. It's happened across the world. There's good reason that policymakers across the world have realized that trying to have an organization that can integrate different forms of care and smoothly transition patients from one part of the system to the next is likely to have higher quality of care. What I worry about here is just people falling through the cracks. If you have one entity managing acute care, another managing continuing care, how are people going to make the smooth transition between those forms of care? We're moving in the opposite direction of everyone else. So I think that's, to me, the biggest concern with all of this.
Yeah, I find myself curious. Like, if you think about, AHS is only going to be hospitals, is the direction that I mean, Smith said it should be called Alberta Hospital Service. Um, and I find myself wondering, historically, if somebody was in some form of crisis, we'll do the mental health and addictions road because that would be siloed separately. But if somebody has the mental health and addictions piece, and they go to the hospital, and the hospital says, okay, we're going to refer you to our AHS mental health and addictions um, service, and they do exist. I mean, I know that there's a pediatric psychology building that's like right across from the Foothills Hospital. That would theoretically, and we can only speculate because we haven't seen the legislation, but based on the documents that have been produced, that would be cleaved off from AHS. And I can't help but wonder, okay, so if AHS isn't going to be running the AHS pediatric psychiatric stuffs, who's gonna take that over?
Yeah, and will that person be able to transition seamlessly from acute care to mental health services in the community? And we just don't know. And I think that we can theorize that it's probably not going to be as smooth as it is now, because why would it be with two different organizations being run in two different ways?
Do you have concerns? And I'm curious, when it comes to like the Canada Health Act,
Yeah.
there's some interesting language that was used in today's press conference, because we saw the question come up. Okay, so what you're saying is Alberta Hospital Services would be the new one of the providers for acute care, but you also referenced Covenant Care as an acute care provider, and you also referenced doctor run surgical clinics as acute care. So now we're talking about acute care existing and there being multiple players in it. Is there room for, you know, Bob's Hospital Co.
Hmm.
Um, if Bob was able to present a reasonable business case, and there was no, that won't happen. The response was, everything's going to be publicly funded and you won't have to pay for it. And that to me almost seems to blur the lines a little bit when it comes to the question of privatization,
Yeah.
because it seemed to me, and I don't know if, and this is why I'm working my way to the question. I'm very long-winded. I apologize, but it seems to me that there's almost a redefinition of what privatization means. Because if you're going to say, well, Alberta Health Services is publicly funded, and so it's not private, and Covenant Health is publicly funded, and it's not private, and the for-profit clinics are publicly funded, so they're not private. Now it seems like with this new model, we're opening up the door for more for profit organizations coming in. And the data isn't great on for-profit healthcare, unless I'm very much mistaken.
Yeah, you're correct. So if we start with the last piece, the data on private healthcare, the context where the data is probably the most robust is in the continuing care context. And what we've seen there is data showing that for-profit operators of long-term care homes, nursing homes, other continuing care facilities tend to deliver poorer quality care than nonprofit public facilities. And so Alberta has a mix of different facilities, but I think that one of the changes as a result of these reforms will be that those facilities that are currently publicly operated are likely to become private facilities. So there will be those concerns in the continuing care context. With respect to the hospitals question, and you mentioned the Canada Health Act at the outset. The Canada Health Act talks about the system has to be publicly administered. And so I think we're still doing that. We're still having the government and these new entities administer it. And then the Canada Health Act talks about how you can't have financial barriers to insured services. And so that's why we've seen this proliferation in Alberta of these private surgical facilities. They're privately run, but the money is coming in from the public system so that patients aren't paying, so there aren't those financial barriers. So it's not privatization in the sense that the Canada Health Act is concerned about. It is still privatization that we should be concerned about, though. There are concerns that these facilities that aren't public hospitals will upsell patients to uninsured services, that they will pull providers out of public hospitals and into these facilities, making it difficult for public hospitals to hire nurses and doctors. There are concerns that these facilities take the cheap, easy cases, and then those people get seen sooner than the sicker people who have to receive, let's say, surgery in a public hospital. So yeah, these private facilities raise issues, and I think that under this model, we're likely to continue to see more of these kinds of facilities popping up and more of these contracts for private entities to provide surgical services compared to acute care facilities.
It seems like in Alberta, historically, as a general theme, the will of the public has largely been we don't want for-profit healthcare. We want public, not for-profit healthcare. And it seems like one of the risks that exists within this new Alberta model, boy, the Alberta models these days, that exists within this new Alberta model is we're going to have not for profit public health care, but we're also going to have for profit public health care. And it's not necessarily privatization in the strictest interpretation of the Canada Health Act, so they'll get away with it. But at the end of the day, I mean, the math is the math and the dollars are the dollars. And so if you have a facility that can do, I don't know, 15 ankle surgeries from a public standpoint, or a facility that's going to do 15 ankle surgeries from a for-profit standpoint, something's going to be giving. I mean, it's the same amount of sutures. It's the same amount of, I don't know, saw blades. And if you're going to have a profit margin, then, you know, the efficiencies very quickly turn into not as good things. Am I reading that wrong?
No, no, not at all. So if we look at the long-term care context where we have the most evidence, we do see corners being cut to maximize profits. Specifically, the corners that we often see being cut relate to staffing. So the number of staff hours per resident, or the qualifications of staff that are working. And so it is entirely possible that we'll see corners cut. We may also see those facilities turning a profit by upselling patients to services that aren't currently insured, some of which may be beneficial, others of which may be just upselling for very marginal benefits. Another thing that we might see is despite the fact that these facilities are taking what should be the cheap, easy cases, because of course sicker people need to be in public hospitals, that they'll take the cheap, easy cases, but the what will be charged will be the same as the average case. And we did see that before. We saw there was a private orthopedic facility in Calgary several decades ago now, and we saw that it cost them more per case to do, joint replacements than it costs in the public hospital. So yes, something has to give. Quality or cost or pushing money back onto the patients, but something has to give. And in Quebec, when they experimented with more private surgical delivery, they found that costs were being pushed back onto the public system where possible. So follow-up appointments or patients who ended up needing rehab after surgeries, that those got pushed off onto the public system. And so they were being paid to do these cases, but then we're deferring costs whenever possible.
One of the other things that I wanted to ask you about from a legal constitutional standpoint, and I know it's been a hotbed issue in Alberta for a while, is I couldn't help but notice that the two people who got the introductions at the start of the press conference were the guy from the Firefighters Association, who was presented as if he speaks for all paramedics, and he definitely doesn't. But following that, there was a gentleman from a faith-based continuing care organization. And we have seen in this province issues where faith-based organizations who administer, whether it's continuing care or administer healthcare, go, we can't do that. That's against our beliefs. And it has nothing to do with the evidence, it has nothing to do with the medicine, it has nothing to do with the science. It has to do, again, with that moral imperative. And, when we see this expansion, and especially when we see the expansion of the continuing care piece that's going to go fully away from AHS, where do the courts side on that? So like here's the question that I'm just going to get to. Let's say that we have an expansion of the acute care because, as the press conference said, AHS is just a contractor to Alberta Health now. And a woman goes in and she's got an ectopic pregnancy. So the pregnancy is, Google it if you don't know what I'm talking about, audience, but it's very bad and the pregnancy is non-viable. And they say, oh, you have an ectopic pregnancy, you're going to need an abortion. But we don't do that here because of faith reasons. Is that a scenario that could conceivably happen? Or is there a legal framework where the facilities are told, no, if you're going to be in this space, then you have to play by the same rules as all of the other players? Because I know that there were examples where people were denied access to maid services.
Yeah, absolutely. There have been scenarios where people wanted access to maid, and there was a situation in Edmonton where the consultation happened outside on the sidewalk. There was another situation in BC where a man was terminally ill and wanted maid, and he had to be sort of schlepped across town in an ambulance, and his daughter had said that it was horribly painful for him and difficult to have that transport to a non-religious facility. So yeah, these are certainly issues that can happen. Where the law stands on these issues is that there is individuals do have religious rights, and that's been interpreted in some contexts as giving providers the right to refuse to provide care where it doesn't adhere to their religious beliefs. So what has happened is some provincial colleges of physicians and surgeons, for example, have said that if you won't provide a service, you have to provide an effective referral. That's been litigated in Ontario. That's gone up to the Court of Appeal, and the Court of Appeal got behind that policy, even though there were doctors arguing that the sheer fact of a referral is objectionable to them. But the college disagreed, as did the court. So there is support in the law for that duty to refer. Some provinces have said to religious organizations, too bad, if you get public funding, you have to provide the spectrum of care. That has not, to my knowledge, been litigated. There's kind of an open constitutional question that's unresolved in Canada about whether those conscientious or religious objections can a corporation have a conscientious or a religious objection? And that we actually don't know. The courts have never resolved that. So there are a whole bunch of open issues, but it may be complicated in Alberta by the potential for legislation that made it partway through to becoming a bill and then sort of fell off the order paper. And that legislation would have actually explicitly protected conscientious objection, would have explicitly protected religious organizations, and wouldn't have allowed the college to put in place a policy like Ontario's saying that you have to refer. So if that legislation reappears, then we could really see that becoming a significant issue in Alberta for individuals seeking MAID, or people seeking reproductive health care services, or people LGBTQ couples seeking reproductive services, trans affirming or affirming care. Like, you can imagine the scenarios that may cause religious objections. And so if that legislation comes back, I think there are various groups that should be concerned with their access to health services.
Yeah, I for me, the conscience or conscious, depending on which iteration of the legislation and who introduced it you want to pursue, I will never get tired of that video. I will never ever get tired of that video. Um, the fact that we have it's not like the guy who introduced that private members bill wandered off into the ether. It's more like he's currently the Minister of Mental Health and Addictions and has been handed this great big thing. But I also find myself wondering, when it comes to the faith-based pieces, are there any legal protections in place for, let's say, let's tie this all together. Let's say that I really like my drugs. Oh, and I'm an atheist. And I overdose because the supply is garbage 3 times in a day. And that's enough for this compassionate intervention to be triggered. And so they say, oh, you've got to get treatment, and we're forcing you to do that. And then I get carted off to a treatment facility that is faith-based. Is there any sort of legal framework to say you can't do that? You can't force people into religious spaces. Is there a precedent for that? Like,
there isn't a precedent, and I'm not aware of sort of, even at the policy level, patients refusing that. I mean, I think certainly patients can refuse religious services within those facilities. So, for example, if a chaplain came around, or there was some form of religious programming offered, certainly individuals do and have refused that. I'm not aware, though, of sort of any litigation around those particular issues, apart from when it's been kind of at that freedom of religion level, and the allegation or the litigation has been by providers. So it's really an issue that hasn't been subject to much litigation. But I take your point that there may be particular approaches to addictions treatment in a religious context that may differ from another context, and that may raise these issues. Because in other contexts, the religion is more tangential, right? You have cancer, and the religion piece is an add-on. The chemotherapy has nothing to do with religion, and whether you want to avail yourself of the facilities, chaplain, or whatever else is an opt-in, opt-out add-on. But I think you're right, in the addictions context, the treatment itself, which could be the kind of therapy sessions or those sorts of things, could themselves be religious based. And so I think we could see an argument there that it's impeding on an individual's, not only their liberty, the fact that they're there undergoing compelled treatments, but that if that treatment has a religious bent to it, I could see them making an argument that this violates freedom of religion, freedom of conscience. But we don't have any cases as the precedents for that, but certainly those arguments could be made.
That blows my mind that we don't have any precedents. Like, if only for the reason that um, we had this problem with these schools for a while, and they were very much faith based. And they did some, and I'm not denigrating faith, to be clear. I say this all the time. My audience hears this all the time. I'm not denigrating anybody who has faith, but I think when you start to use your religion as a cudgel, you're crossing some lines, maybe. Um, and it's fascinating to me that we don't have any like, hey, so taking people off to religious institutions to re-educate them, that should be illegal.
Well, if you're referring to things like, of course, residential schools and those sorts of things, yeah, there has been litigation there. But the litigation didn't tend to be freedom of religion kind of arguments that were made, but rather arguments for example, there were negligence cases where it was argued that the treatment that was received was negligent, or those sorts of things. Those are the arguments that have tended to be made. I'm not aware of charter cases like that, but there may be charter cases in the educational context somewhere. But in the health context, at least, this would be something that is still to be determined.
That's wild. That's just I'm just very surprised by that. See, this is why I like having conversations with people who know things more than me and are way smarter than me, because I get to learn something. It's fantastic. Um, what are the big so let's run through sort of the list of what we went through, because I want to hear what your big concerns are. What are the things that you're going to be watching for? So with the CMOH piece with Bill 6, what are the things that you're looking at and going, oh, this is going to be interesting to see how this plays out?
Well, I think unfortunately we won't really see what happens with the CMOH until there's a public health emergency. In some ways, we don't know how the cabinet will behave until they're actually faced with the choice. But in the shorter term, I think I'll be curious who the CMOH will be. Is it going to be hard to recruit someone as CMOH, given the political past and given the new legislative context? And what approach will that person take? Will they be a figure that is very in the background advising government, or will they be a figure that has more of a public presence? Even if there's not a public health emergency, do they have a public presence in things like the recent daycare E. coli issue that we saw? So I think with the Public Health Act, unfortunately, it's a long game that we're going to have to see how that plays out.
I guess it all depends on whether or not the given health crisis is pressing, or whether or not public facing is a priority. But
Yeah.
it's just me speculate. I'm not even speculating. That's what kills me on this. Okay, so that's the CMOH stuff. What about the forced treatment? What are you going to be watching for there? What are your biggest concerns, other than I'm not
Yeah.
going to put words in your mouth.
Well, I think in the long term, I'd love to see what happens in a charter challenge when the government is made to show the evidence. Well, what evidence do they have? Show that you exhausted other less impairing policy options, which we know they're not. So I think in the long term, that could also be interesting. In the short term, I want to see what the legislation says. How high does it set the bar to compel individuals to undergo treatment? What criteria do they have to meet to be in the category of someone who is forced to receive treatment? What procedural protections do they get? Can they challenge this determination? What does that look like? What does the process look like? How long are they allowed to be held under the legislation? Is it a sort of a short temporary detox hold, or are they allowed to be held in facilities and treated for longer periods of time? So what does the law look like is the big question in that context.
Yeah, I have so many questions about that one, because, like, to me, if the concern is, oh, they're using drugs too much, they're going to overdose. If I'm that person, I'm going to be like, oh, you know what? Thank you so much for holding me for 24 hours. I'll never use drugs again. And then I would go and use my drugs.
Yeah. I mean, it's sort of a catch-22, isn't it? Where you obviously legally the law would want you to hold people for as short of a time as possible, so you're not intruding on their liberties to a great extent. But of course, to effectively be treated, that would lean more towards a longer term of treatment, and that's why I think we want these options available to people, but we want them available so that they can choose them. And we want a broad spectrum of other options, including safe consumption, to be available for those who aren't there yet and aren't ready to do the recovery thing.
Yeah, I always go back to the old joke. How many psychiatrists does it take to change a light bulb? Only one, but it's got to want to change.
Yeah,
And
yeah.
I think there's a lot of truth in that one. What about AHS? So the time frame for this thing in some instances is pretty fast, and I mean, I think they said that they want to start moving on the AHS stuff like right now, and then they're hoping to have the mental health and addictions done by spring of 2024, and then they'll figure the rest out from there. What are your concerns? What are you watching?
Well, I think the concern is just the siloing is going to lead to people falling between the cracks. That's a big concern. The other big concern is that this doesn't solve our actual problems, right? If one of our big problems is this human resource issue and attracting doctors to the province and having patients have a primary care provider, I don't see how any of this fixes that. If I was a doctor and I was looking at my different provincial options and where I might want to start my career, I don't know that I would want to go to the place where the system is in chaos and the government is expanding their authority and they're breaking things up, and like that just sounds chaotic. If I had various good options on the table, I'm not sure that I would pick this unstable, chaotic system in Alberta as my choice. So I don't think it solves problems, and I think we're likely to see that in the long term, right? If we look 5, 10, whatever years down the line, did this significantly improve patient outcomes? I don't think the answer is going to be yes. Um, I think I'm also watching for the cost. I think it was very telling that in the press conference today, the government would not cite a dollar amount for this transition. They kind of nodded to what it cost in 2008 and then left it at that. Either they don't know what it's going to cost, which is a huge problem when you're embarking on such a potentially significant thing. You need to know how much it's going to cost, or they do know the cost and they're just not willing to share it. And like either of those scenarios are problematic. So I'll be watching for what this costs in the long term. So I think those are the main things in the longer term. Maybe in the immediate term, just watching who do they appoint to these new organizations? What does the legislation look like? Who has what powers? What specific accountability mechanisms there are? So basically, just the details of all of this.
I mean, it's not like the provincial government has embarked on any major initiatives recently without having any concrete numbers to provide to people. That's clearly a standalone incident.
Yes, yes. Something we've seen before, yes.
Yeah.
But it could be so expensive. The creation of these new organizations, consulting with the public, all of these things. And one can't help but wonder if the money wouldn't be spent better on direct patient care, on frontline staff, on all of these things that we know we need. And I just worry that this is going to throw the whole system into chaos when it's already struggling. I mean, just the transition of just lab services, which is such a tiny aspect of the healthcare system, tiny but important, that was a disaster. We haven't seen yet the costs on that. I think we may from the Auditor General, but the just what a disaster that was, transitioning that over. And now we're going to do that with the entire system. I just don't see how that's going to be successful.
Well, and maybe the labs too. That was the two little fun pieces, and by fun I mean we're doing that then, are we? The fact that they've said, hey, you know what, for labs, we're going to give it a year, and then we're going to see what the new AHS board wants to do. And they said the same thing for emergency medical services as well, where we're going to give it a year and see where the board wants to do. I'm curious, the chair of the board, he's got a little bit of history in the medical space and in the political space. I was fascinated at how his introduction at the press conference was just like, oh, he's a doctor and he does rural healthcare sometimes. And I mean, if you want to call, I think it's Vietnam, rural healthcare, I guess you could, but he has a history with forms of private health care. Certainly, some of his current ventures allegedly have him working for organizations that could potentially stand to benefit from this. Is there any sort of conflict of interest flags that go up for you, or is this one of those like, well, they get to do what they want because elections have consequences?
It's a bit of both. It is, they part of winning the election is not just that you make decisions, it's that you get to appoint people to a whole slew of boards and tribunals and committees. And I think sometimes we forget that you can get rid of elected officials at the next election, but their influence stays around until you can change all of those bodies that they made all of those appointments to. And so in some ways, yeah, who you get is gets to be decided by who's in charge. I think with respect to this particular individual, yeah, I think it was curious that they focused on his sort of medical qualifications when it seems that he maybe is more focused on other ventures, and he has had a political past. None of that was really mentioned. I would have hoped that they would have picked someone who's currently in a high role, perhaps in AHS, or someone who is on the AHS board, or someone who has been on the AHS board, or someone with significant experience in healthcare governance. I would have liked to see an appointment that was more focused on the expertise and the necessary qualifications than perhaps someone who is politically aligned with the government.
Okay. The question that I'm hedging a little bit is in February of 2021, there was an announcement from an organization called Equity Health Services that he was joined, or he was nominated to the Strategic Advisory Board for Equity Health Services. And when you go to the Equity Health Services website and you take a look at the services that they offer, diagnostic services, chartered surgical facilities, mobile testing, advisory and counseling, emergency infrastructure, like he's very, very recently had a it appears to be pretty substantive interest in private healthcare, and he's going to be the chair of the board that's deciding whether or not AHS keeps lab services and EMS. Like, is there any sort of conflict of interest rules that get triggered here, or now that we fired the ethics commissioner, is it just do what you want?
Um, it's been a while since I saw it, but I'm sure AHS has a conflict of interest policy, although I'm not sure it would be binding on the board. I think they have one for staff and whatnot. I'm not sure if it would be binding on the board, but I think you're correct that if they've appointed someone who is friendly to private options and for-profit healthcare and chartered surgical facilities, that's telling, right? They have a whole slew of very qualified people who either work in AHS or have worked in healthcare governance or have extensive public sector expertise. Like, it's not that they had a shallow pool of talent to draw from, and the fact that they pick someone who is politically aligned with them, and who has these ideological views around privatization. I mean, I think that's telling for what values they have with respect to the healthcare system. And this isn't the first time this has happened. They appointed someone to the board previously who had written papers and voiced his approval of private healthcare as well. So it seems that there are those voices in AHS, and that the government is going to continue to appoint them to these kinds of leadership positions. I think we could see the same thing when they create a board or the entity to govern this new continuing care organization. Will we see that organization dominated by voices from the for-profit continuing care sector as well? And I think the answer is yes, we may.
Yeah. My last question for you. Um, there are a lot of people who are watching this legislative session, and I don't feel like I'm being hyperbolic when I say certainly high levels of anxiety, and based on some of the messages that we've gotten, abject terror. What would you recommend people do if they have concerns about the direction that things are going, because we're kind of screwed for the next 3.5 years from an election standpoint. Are there any recommendations that you have that people can avail themselves of if um, that's something that they want to do?
Yeah, so I think that a couple of things. I think that, this is a government that keeps legislation and policy decisions very close to their chest. And so that gives people limited ability to influence decisions before they happen, because things just happen here. And even people who work in this space often don't find out until the last minute, and so it doesn't seem like there's a lot of expert consultation. They hold things very close to their chest. And so I think that it's hard to be able to influence those big decisions. But I think once those big decisions are announced, certainly people can apply pressure to their own elected officials, to the opposition elected officials, as to how the details of those things will be sorted out. I think as well, people can try and look down the line at the kinds of policies that the government is looking at and make their voices heard on those things before they become policy. So, for example, the UCP just had their annual general meeting and voted on a whole slew of resolutions. Those are things that people can try and make their voices heard on now, knowing that they may become policy down the line. Individuals can also, there's a lot of experts out there commenting on various political or various policy issues, economic issues, natural resources issues, health issues. So individuals can certainly find those voices and use them to try and hold the government's feet to the fire. Just this week, there was a paper that came out that debunked the government's report on supervised consumption, and that's getting a lot of publicity, and people are holding the government's feet to the fire. Will it change their mind on that issue? Maybe not, but the more that people do that, the more likely it is that we'll see changes. So just calling out the government if you see things they're doing that don't accord with the evidence. And then, of course, finally, the next election will come sooner than people think, and so getting involved in that early. I think if people are passionate about these issues, they can certainly do that. They can get involved with their local constituency associations. They can donate. All of those things are helpful.
Perfect. Dr. Hardcastle, is there anything else that you want people to hear? You brought up the UCP AGM. I was trying so hard because that's a whole other rabbit hole to go down.
Yeah.
Maybe we'll bring you back for another conversation about all of the wonderful implications. And I just don't understand how people vote for that stuff. I just can't wrap my head around it. But is there anything else that you want people to hear? Is there anything else you want people to take away from the conversation?
No, I think people just need to continue to inform themselves on these issues, continue to try to make their voices heard by elected officials, and ultimately to take care of themselves. I mean, if this isn't a government that's going to tell you to get vaccinated, this isn't a government that's going to tell you to wear masks if you're immunocompromised. And so ultimately, you have to fend for yourself a little bit and find those expert voices and do what needs to be done to make sure that you stay healthy and safe.
Awesome. Dr. Lorian Hardcastle, I want to thank you so much for taking the time to chat tonight and reinforcing how much trouble we're in.
Thank you for having me.
Yeah, thank you so much.
And that's it for another episode of The Breakdown. As always, if you appreciate the kind of content that we're trying to produce here, we would love nothing more than if you thought about signing up to be one of our Patreon sponsors at www.patreon.com/thebreakdownab, where for just the price of a fancy cup of coffee a month, you can help us continue to produce this kind of content. Whether you're listening to the audio version of the podcast, in which case, maybe leave a review and a rating, or whether you're watching it on one of our streaming platforms, we want to say a big thank you to everybody who is part of the Breakdown's audience. And as always, take care of each other and keep the conversation going.